Good morning, everyone, and welcome to our webinar. My name is Kim Houghton. I'm the Chief Economist here at the Regional Australia Institute. I'd like to begin by acknowledging the traditional owners of the land and pay my respects to their elders, past, present and emerging. I'm coming to you live from Ngunnawal land this morning. We welcome any First Nations people joining us today from around the country. Welcome also to our fourth Regions Rising webinar in our series this winter. Our focus today is on the health sector in regions and how it can contribute economically to regions' recovery and what the changes in the health sector that COVID-19 may have brought to regional Australia. Please welcome our three speakers today, our three guests. Gabrielle O'Kane, CEO of the National Rural Health Alliance. Welcome, Gabrielle.
Morning.
Catherine Maloney, CEO of Services for Australian Rural and Remote Allied Health. Morning, Catherine. And Lyndon Seys, CEO of Alpine Health in Victoria. Welcome, Lyndon.
Thanks, Kim.
All of those who've registered for the webinar should have received a link to their bios in the reminder emails from Zoom. Now, I should let you all know the session is being recorded and we'll make it available later online this afternoon, including the slides from the presenters. We're also streaming on YouTube live to enable people that don't have access to Zoom to follow the webinar as well. There will be some media on the line as well today. Please don't forget to get vocal on social media using the hashtag Regions Rising, and also you can tag us on Twitter at Regional Aus, that's Regional AUS. Before we get started, I would like to acknowledge and thank our Regions Rising National Series sponsor, the Bendigo and Adelaide Bank, and their charitable arm, the Community Enterprise Foundation. Without them, we wouldn't be able to continue delivering these free webinars, which I think have been really valuable in keeping us connected during these somewhat strange times. So thank you very much to Bendigo and Adelaide Bank for their continued support and for their obvious commitment to regional communities. We only have an hour today, so I won't wrap it on. We'll make the most of it, and we'll have plenty of time for a bit of Q&A towards the end. You can submit your questions anytime throughout the session using the Q&A function in Zoom. Make sure to write your organisation name or where you're from and who you're directing your question to, if that's particular. If your question is chosen, my team here will enable your microphone so that you can ask it personally. It's a nice thing that we've worked out that we can do to bring some other voices into these conversations. We have received some questions in advance, and hopefully you'll hear some answers to those during the session today. As many of you will know, the health sector has been a really important issue for us at the Regional Australia Institute over the last 3 or 4 years in particular. It does fill this really interesting sort of dual role. It's an enabler that enables regions to be sort of vibrant and livable places in their own right, but it's also been a major contributor to employment growth, skills growth and income growth in many parts of regional Australia. And I hope to explore some of those issues today with our panellists. So to start off, I'll invite Gabrielle, CEO of the National Rural Health Alliance, to make an address. Thank you, Gabrielle.
Thank you very much, Kim. And I'm just going to share my screen with my slides for everyone. Ooh. Is everyone able to see those slides yet?
We're not that short of time, Gabrielle. You do have time to go through them.
Can you see that now?
Yes, we can. Yeah.
Very good. Okay, thanks very much for this opportunity. And look, what you asked me to do was about how the health system has coped and adapted during COVID-19 and how we might transition into the future. So the initial government response from the Australian government perspective was about establishing the GP-led respiratory clinics, including in rural, regional and remote areas of Australia. And initially there was a funding of 100 of these from federal government, but we're now sitting at 145 of these GP-led clinics. And interestingly, for rural Australia, there's about one GP-led clinic for every 85,000 people. So we're actually travelling better than there is in metro. But one of the other very quick things that government responded to was the Biosecurity Declaration in 2020 that was made under the Biosecurity Act of 2015, and that came into force on the 18th of March. Now, this meant that there was travel restrictions to and from Aboriginal remote communities to protect the health of communities, but also to protect the cultural heritage of those communities. At the same time, the states and territories were sort of ramping up their emergency departments and decreasing things like elective surgery for the time being, and certainly getting familiar with all the PPE and the donning and doffing and that sort of thing. So then when it came to telehealth, this has probably been the most important change that's happened for health in this past pandemic. So first few stages of the rollout of the Medicare items was originally focused on specific patient groups and also for the protection of the GPs and specialists as well. But by March the 30th, stage 4 at that stage had moved to the whole of population for all Australians for a wide range of services, including for allied health. Now, there's been a couple of surveys that have been done just recently, one of them being from the Royal Australian College of Physicians, and the other has been from the Continuity of Care Collaboration. And the advantages really of telehealth that have emerged out of that is that patients actually felt safer because there were issues around sitting within surgeries. Also increased accessibility to healthcare, and interestingly, 70% of the specialists that were surveyed said that their patients were more likely to keep their telehealth appointments. So that tells you about convenience. There was no need to transport, to get transport to clinics, and so there was a lot of time and cost save in doing that. And rural patients were consulted closer to their home. And some may not have been able to get any care if it weren't for that telehealth. So this has been a huge change and a huge benefit. And of course, more frequent and shorter consultations as a result. Of course, we can't ignore the fact that face-to-face appointments are always good. They're much better in terms of assessment, examination, and building patient rapport. And it's also easier for patients with cognitive impairment, hearing, sight impediments, language barriers, that sort of thing. And it's still classified, of course, as the most superior quality of care. Then, in terms of disadvantages of telehealth, it was interesting that 28% of the sample in the Community of Care Collaboration survey, and there were over 700 people in that survey, found that telehealth could be difficult to use. So it was the technology was often a difficulty. Things like using, whether we're going to be using video conferencing as opposed to phone. The video conferencing was more challenging, particularly for the elderly when there were lack of familiarity about video teleconferencing. And I should say that when it came to the percentage of GPs, for instance, that were using teleconferencing over telephone, it was actually, it was something like 96.5% was by telephone rather than video conferencing. So I think there's some interesting things going on in that space that we might have time to talk about when we come to a Q&A. Many Indigenous patients didn't like telehealth or phone calls, according to one of the surveys. So the challenges, though, in face-to-face during COVID has been that 52% of people were actually avoiding or delaying going to their medical appointment. 23% were concerned about breakdown of lockdown rules, and some services weren't actually offering face-to-face services. There were travel restrictions for some living in remote areas and like no crossing of borders, and we know that those things have become a bit more of an issue just even in the last month or so between New South Wales and Victoria, but also New South Wales and Queensland. And patients didn't actually want to become a burden. But of course, what this actually revealed, this move towards telehealth, was that it tells you that government is actually able to respond really quickly. There's a will, but there's also a critical need. And I think that we need to actually sustain these telehealth services into the future and maximise those benefits for our community, but also ensuring, though, that we've got a sustainable rural workforce in the bricks and mortar situation as well. So we've got fantastic opportunities to make better use of telehealth. but there still are quality and equity considerations. So things like poor connectivity in rural areas still has to be addressed. Video conferencing is still considered a much better option, but does require good bandwidth. There's issues around affordability of good internet services for those in rural Australia. And we would be proposing that new MBS items for multidisciplinary team meetings using video conferencing could be a really helpful way for improving coordinated care. I think the other issue that we want to highlight today is about considering digital health issues. So there are significant differences in digital inclusion that persist between urban and rural, regional and remote areas. Barriers include the connectivities, but there's also compounding issues in rural and regional Australia. So they're things like, you know, poorer health, so their chronic diseases are an issue. There's an older demographic. There's also lower educational levels and just general digital health literacy. And then there's a need for programs as well, we think, in terms of improving digital health literacy amongst consumers, but also for health professionals in rural, regional, remote areas. People have had to learn very quickly, but there's still opportunity for improving that even further. In terms of then considering the actual impact of COVID-19 for rural, regional and remote areas, there's been a differential impact on rural and regional. For example, regions are relying very much on international tourism being affected very badly. You know, places up in North Queensland come to mind very strongly at the moment, as you might be aware. Border regions are still a challenge because there's access to healthcare. It's been significantly impacted. Long-standing critical shortages of the health workforce in rural and regional areas that has been exacerbated by the pandemic. You know, the backfilling ideas, people having to be in quarantine. There's supply chain issues from a national and international movement. The PPE has been one of those examples. And of course, there's been food security challenges that have been exacerbated in the remote communities, particularly in rural and in Aboriginal and Torres Strait Islander communities. There's a clear link when we're thinking about recovery. There's a clear link between poverty, financial distress and poor health outcomes, including mental health. So there needs to be a continuation of an economic safety net that's critical for ensuring that people that aren't living, that they're not going to be living in poverty and can spend at levels to stimulate the economy. We've put out a position statement around that. There's stimulus of investment, shouldn't forget rural and regional Australia, and we shouldn't just be focusing on infrastructure. It's important to actually be investing in people. So investing in the rural health workforce is really important. And it's been interesting that the Australian Institute has done an economic analysis and has indicated that industries such as health and education have a much higher direct employment effect per $1 million of spending. So we should be investing in that health workforce in disadvantaged regions for stimulating the economy, but also addressing those workforce shortages. And there's also concerns that we have regarding the pipeline of healthcare workers due to the challenges of organising placements that have occurred this year. There's a whole lot of supervision issues and pressures on universities. So I just thought if you wanted more information that you would like to go to our website and our Twitter account, Facebook and our LinkedIn account. So they'll be shared for you this afternoon. So thank you very much.
That's terrific, Gabrielle. Thank you very much. I'm sure that's sparked a few questions. It certainly sparked for me a bit of I hadn't really thought very much about the difference between telehealth and video health. I sort of assumed that it had all gone video because they're the pictures that we see in the media, but in fact, the vast majority of it's still tele-based. So and it's nice. Thank you for pointing out some of the strengths and weaknesses of that approach. And of course, the other one that really worries a lot of us is that border restriction. We've already had difficulties recruiting and retaining skilled health workers in regions anyway. Border controls haven't helped. And then if you think about the need to have a sort of a doubled up workforce in case some of the frontline workers get taken out of the system because of infection, then that just makes that whole need for they're not skill shortages so much as outright labour shortages. It makes the whole need for that even higher. So
higher, exactly.
Much for raising some of those very important questions. I'd now like to invite Catherine Maloney to talk to us. Catherine's CEO of SARRAH. Thank you, Catherine.
Sorry, just had to unmute myself. So thanks, Kim, for the introduction, and good morning, everybody. I too am sitting on Ngunnawal land this morning and wish to acknowledge the Ngunnawal people as traditional custodians of this country. I pay my respect to all Aboriginal and Torres Strait Islander peoples across Australia, and particularly to those who may be joining us online this morning. So who is SARRAH? We're a small not-for-profit organisation representing allied health professionals working in rural and remote Australia. Some of you will already know who we are. SARRAH exists so that people living in rural and remote Australia can access the allied health services they need to enjoy the same levels of health and well-being as our family, friends and colleagues living in Australia's cities. SARRAH represents around 25 professions, including physiotherapists, psychologists, speech pathologists, pharmacists and more. Our members work all over Australia, in hospitals, community health and community-controlled primary health centres, in private practices, in schools, disability and aged care services. While there is no definitive workforce database for allied health, it's conservatively estimated that around 195,000 allied health professionals around Australia deliver approximately 200 million health services annually, providing diagnosis, treatment and rehabilitation for a broad range of health and related conditions. I wanted to start by talking about the impacts of COVID-19 on allied health services generally. During the national lockdown period in April and May this year, there was a 26% reduction in MBS items billed for allied health services delivered as part of a chronic disease management plan. That's nearly 382,000 fewer sessions than for the same period last year. Of these sessions, only 4.5% were delivered via telehealth. I'll talk about some of the challenges that might have contributed to this statistic shortly. During lockdown conditions, our members consistently reported a downturn in activity. There were drops in client numbers anywhere between 15 and 50%, especially during the higher lockdown levels. Greater impact on practices located in border towns due to border closures, preventing movement of clients across state borders. There were high reports of mental health concerns, especially a high level of frustration for loss of continuity of routine care. And there were higher administrative load for practices in terms of the screening of patients, telehealth setup time, and access to personal protective equipment. In general, allied health professionals adapted very quickly to be able to deliver services by telehealth. On the upside, the transition to delivering services via telehealth was relatively easy as the technology is readily available, and many practitioners were already using it to varying degrees. Some practices founded on telehealth actually experienced an uptick in business during the lockdown, arising from an increase in demand for telehealth delivered services by clients, and also other health professionals seeking support to transition to telehealth-based practice. The challenges were largely felt by patients rather than the health professionals, as reported by our members. They reported that clients placed a higher value on face-to-face service delivery, especially for the physical therapies like physiotherapy and exercise physiology. Clients in rural and remote locations experienced a lack of access to stable internet connections and bandwidth. People from lower socioeconomic demographics were challenged with the affordability of data and devices, and older people were generally less comfortable with the technology and less inclined to engage with it. Some practices were able to devise workarounds for some of these issues. Where connectivity was an issue, clients travelled to town to access stable internet connections, for example, at schools and libraries. Therapists used key workers at the client end of the therapy session. This may have been a family member or a qualified therapy assistant. And good results were found when the allied health professional invested time to train clients and families in use of telehealth before a therapy program commenced, so that the client could focus on the session rather than the technology. This pandemic has clearly demonstrated how the nation's health and its economy are inextricably linked. I'm now going to outline why the health sector can and should lead the way to economic recovery. I'll preface my comments by acknowledging that I'm focusing on the allied health sector specifically. Yes, medical and nursing services are crucial to the health sector, but as the least understood sector of health, the allied health sector makes an interesting case for a health-led economic recovery. In late 2019, the Regional Australia Institute published a report on the healthcare and social assistance industry, predicting that this sector will be the fastest growing by 2023, with 34% or approximately 80,000 jobs located in regional Australia. Personally, I suggest this figure of 34% is an underestimate, given the severe shortage of allied health professionals outside of metropolitan Australia, suggesting that we need to see proportionately more jobs generated in regional Australia in order to achieve a level of parity with our city-based cousins. Not only that, but chronic workforce shortages mean that jobs creation alone will be insufficient to meet the future needs of rural Australians. Targeted strategies are required to grow a fit-for-purpose rural allied health workforce. In December 2019, the government released its report on jobs for the future in regional areas. It lists mining and power generation, agriculture, service industries and manufacturing as key to unlocking new job opportunities. But the report is silent on the future of health and social services in regional Australia, despite numerous submissions, including our own, calling for a focus on health workforce. Planning for growth of regional communities without a complementary plan to grow rural health and social services risks exacerbating the significant gap in health outcomes, equity and access between metropolitan and rural Australia. Consider the Australian Institute of Health and Welfare's reports on the disparity of health outcomes between regional and metropolitan Australia, including Aboriginal and Torres Strait Islander people, and we can start to join the dots between reduced access to allied health services and poorer health outcomes. That is to say, the people who need allied health services the most are least able to access them. Investing in the health sector makes good economic sense. The World Health Organization estimates the return on investment in health to be in the order of 9 to 1. 1 year of life expectancy has been shown to raise GDP per capita by about 4%. In 2015, SARRAH published a report on the economic impact of allied health that showed interventions and programs involving allied health professionals have the potential to result in considerable savings to healthcare budgets in Australia. The potential savings from the reduction in incidence of things like chronic heart disease, kidney complications, hip and knee replacements, amputations and premature entry to aged care as a result of allied health interventions was estimated to be nearly $78 million annually at the time this report was released. Yet poor access to allied health services limit capacity to realise these savings, let alone realise the health benefits for Australian communities. Couple these estimates with the billions in unspent dollars under the National Disability Insurance Scheme, and a picture emerges of a vastly underutilised and untapped potential. In June this year, the former National Rural Health Commissioner, Professor Paul Worley, delivered his report to Minister Colton on the improvement of access, quality and distribution of allied health services in regional, rural and remote Australia. He detailed a number of recommendations that, if implemented, will go a long way to building a fit-for-purpose, high-quality rural allied health workforce. The key here is in the implementation. Specific, targeted investment by all levels of government is required to address the severe shortage of allied health professionals in rural and remote Australia. Let's stop and think for a moment. If investing in the health sector reaps big economic returns in terms of increased workforce participation over a longer period of time, and investing in allied health has potential to save millions of health dollars each year at a time when the health budget continues to grow exponentially, and having better access to allied health services is likely to improve health outcomes for rural Australians, then investing in allied health workforce and services seems a logical and low-risk strategy towards economic recovery for rural communities. So envision for a moment a health-led recovery. Investing in the health sector will return dividends in terms of increased productivity of the entire workforce through high participation rates and reduced lost work hours, better health and education outcomes for our children. Working with Aboriginal and Torres Strait Islander communities, a better chance of closing the gap across a number of indicators. Increased social and economic participation for people living with disability, and better quality of life for older Australians living safely in the community for longer. All of this and a 9-fold return on investment it just makes sense. Thank you.
Thank you, Catherine. That's a wonderful vision for the role of the sector in regional economic development, regional economic growth. Thank you very much. I think it is really important to we reflect on the actual viability of a lot of our regional communities. Really does depend on the breadth and diversity of health services that are available, and increasingly we're understanding the value of those allied and well-being related services, which are all sort of post-hospital, outside the sort of the formal treatment of illness part of the system. And I think that's a really important part of the package. So thank you very much. That some of that research that Catherine was referring to, that the Healthy Checkup, has just been put on. Will be passed through to participants through social media this morning, and we'll refresh the links on our website to that document too, if that's of interest. I'd now like to invite Lyndon Seys to address us, giving a community perspective on how to build a really viable and interesting regional health service in a rural area. Thank you, Lyndon.
Thanks, Kim. I'm going to start on the assumption that people have had a look at what you've produced, Kim, in terms of the case study, but I'll digress and I'll come back. The Alpine Health is a multi-campus health service established under the joint Commonwealth State multi-purpose service program. It was a decision that was taken in 1996, at the same time as the three organisations decided to amalgamate and become one, each one of which was facing some difficult financial times, and each was looking for a strategy for moving forward. At the time, if you put it just in cold hard dollars and cents, the organisation was effectively running 3 very small hospitals and 3 very small residential aged care services and an even smaller district nursing service, and that was about it. It was in operating deficit very early on, and so the money became everything really in the early stages. They've turned over about $7 million in 1996. It's about $34 million today, given all things. And that's become, that was made possible over time because of the conditions around the multi-purpose service program. It brought with it an obligation for population-based service planning, that's population health-based service planning. And that in the end has proven to be the way forward, not on its own, of course, but as a really important way of bringing people together and understanding how the service could actually become part of and respond to community need. During that time, of course, it was important for the organisation to understand how it could do that. And in Victoria, where we are incorporated, we operate under Victorian state legislation. The principle of local governance was in place, and it still exists. And I often argue around the importance of local governance from the point of view of local ownership. I mean, every one of our small communities owns their health service in their minds and in reality. And that formed the basis of being able to have a relationship with a community once we got the processes right. As you can imagine, amalgamation is a joy everywhere, and small communities are very precious around their health services. But they already had ownership of it through things like volunteer groups, auxiliaries, local board directors and members, and a number of vehicles that gave effect to that ownership. And I often talk about, it's in the case study, that we had 9 volunteers in 1996, all of whom retired in 1997 because they had come to the average age of 82. Today it's a bit different than that. We have more than 350 And that came because of the need to bring the communities together and find a strategy. At the time, of course, there were 3 vehicles. You know, each community had established a focus group to keep an eye on the board and make sure their community benefited from the amalgamation. And it was just simply a focus on each of the communities. But once we started the service planning work around population health, then the world started to change. And the groups, they were called focus groups in the early years, and now they are advisory groups, and we have on average about 60 members of our communities with those groups around a planning process that is all community based. So we have a 5-year strategic plan, and we have annual plans, and each year those communities come together with our workforce and the board to determine what's really important, what the need is, and how we address it from in the ensuing years. And behind all of that is some work that's also done with our communities around scenario planning. And back in 2008, we built the kind of scenario, without naming the pandemic, that we currently find ourselves in. Now that planning, the strategy planning and the operational planning coming together with long-term thinking has enabled us to survive many things. I did the numbers in my mind only a few days ago. In the last 20 years, looking beyond the bigger economic crises that Australia has faced, including the more recent global financial crisis and the dot-com crisis and the Asian bank crisis, our 3 communities have lived through 5 bushfires and 2 floods. So we, like all rural communities, quite capable of responding to the kinds of circumstances that we find ourselves in today, and that's formed the really important basis of our survival and our growth. Crises are no longer just matters for us to manage and get through. They actually provide us with opportunities that are important to us. In the lead up to and through the early stages of the GFC, for example, we really struggled recruiting nurses. At the same time, our planning told us, our workforce told us, that half of our workforce had not achieved any education after high school. So half of our workforce was only secondary school qualifications. So that led us through our relationship with the community and a relationship with the workforce to establish a registered training organisation, which is now a big part of our business. So when you look at the development of strategy and its operationalisation through the COVID environment that we're currently living in, 2 really important things have come. One is, because of the work with the RTO, we actually had a ready-made workforce. Yeah. Because of and this is true, we have 30 EN students in our work in the Institute at the moment. We have another dozen or so RNs in the Institute at the moment. So we had a ready-made workforce of more than 40 people who we could put into basic frontline work like screening for COVID and additional PCA support for our residential aged care service delivery. At the same time as we had a strong commitment to the use of technology, and now having lived through many years where people were suspicious of the use of that word telehealth and video conferencing, it's now been taken up with a high degree of alacrity. And I'm not just talking about video conferencing either. I mean, there are a raft of technologies that we've been using to support rural communities through technology for a long time, but now we have communities that recognise the value of it. I think the final thing that I'd say is that in amongst all of the things that we've been able to do, that the multi-purpose service philosophy and the framework that brings with it, the bringing together of dollars and cents from all sources, the Commonwealth and the state, from our own capability, and then to allocate it across need according to the times, has been one of the most important things that's enabled us to work. And it enabled the development of the RTO. It enabled the expansion of our community health services in the early days when we couldn't get funding from other sources and address real issues. I've spoken, and I'll use this as the last of my examples, but when in 1999, from 1997 to 2001, the organisation had some funding from the state for addressing adolescent suicide in one of our communities. And that funding was project-based and ended, but the community anxiety around suicide didn't go away. So we just stepped up and said we would do this. In fact, we extended the program across all 3 communities from a single one. As a consequence of that, we've had no adolescent suicides, not successful anyway. I don't know if you can put it any more kindly than that, for more than 20 years. In fact, it's 24 years. So therein lies Alpine, part of Alpine Health's story, and our response to the situation we find ourselves in right now.
Thank you, Lyndon. That was terrific. We've known Lyndon for a while now. We have a lovely case study of Alpine Health, its growth, its purpose, its foundations, its activities, which is being released right now through social media and on our website. And I'd really encourage you to have a look at it, because it does actually address a number of the things that we've got. We're getting a lot of questions about rural workforce, rural health workforce, allied health in particular. And I think if you listen to Lyndon's story and you look at what they've done there, there's a couple of key themes there around local ownership is a really big one. I love, Lyndon, towards the end you were talking about what's effectively sort of joined up funding, which is the holy grail of a great many sort of state and federal governments, but you're actually doing it from the ground up. And then tying that in with the training arm, that allows you to sort of develop your own workforce. So, but I think so please have a look at this if you're interested in that case study. It does really touch on a number of really important themes that the Institute's been concerned about for quite some time, and it does show how much can be done in a rural setting. What I'd like to do actually is ask each of you now to comment on some aspect of this health workforce attraction and retention issue. There are many different aspects. We've got everything running from, subsidies to get doctors to train and complete their training in rural areas, right through to what Lyndon's doing, which is, growing growing the competencies of a volunteer workforce, everything in between. But I know you'll all have views on this, but if you have any sort of suggestions or ideas or sort of priorities that your own organisations are working with each of you in terms of attracting and building and retaining that health workforce, I'd be grateful for any commentary. And I might start with you, Gabrielle.
Oh, thanks very much, Kim. Yeah, look, there's so many aspects to this, and you've just pointed that out. And I think the way in which Lyndon was talking there, I think it is a lot about this sort of pooled funding kind of model and starting with your own community and building from there. So getting an understanding of what the needs are within those communities and what the priorities of those communities are. But we do need to be combining funds from both the Australian government and state government. Look, because gone are the days, I suppose, when we had a really strong community health workforce that were employed through state and territory governments. They become sort of more of the subacute sort of services. So if we want to get into that prevention, health well-being kind of thing, we've really got to look at the way in which we can do that more effectively. And I think we've actually got to do that in a more sort of coordinated, integrated type of way. I think to achieve those things, the starting point does have to be about education of young people in the bush, getting them attracted into doing health courses in universities. then trying to make sure that those, regional universities are actually being able to address, to have those courses available to rural students would be really worthwhile. Yeah. And having those placements in rural areas too. So when they go out on a clinical placement, it's not just about having, say, 2 weeks in that rural environment, but actually trying to extend that. So if you have a student that is from a rural area, then give them a really good opportunity to sort of stay and network within that rural community. So I think that's about the student sort of stuff. And making sure that we're attracting kids that are from the bush to be able to come back and do that sort of work. Look, I was a city girl that went to the bush and stayed, and it was because, I met my husband in the bush. So those sort of things really do matter. You've actually got connections, and you build a life in that way. So there are those other sorts of things. There's incentives, I guess, from even a monetary point of view. I think for allied health, and Kath will be able to expand on these sort of things, but at the moment, the MBS item amounts to about 6% of the expenditure. So then allied health have to then look at, the NDIS aged care packages. So in small communities, it can actually be really difficult for an allied health professional to make a living if they're in private enterprise or a private practice. So I'll let Kath expand on that.
Yeah. Thanks, Kath.
Thanks, Gabrielle. Yeah, absolutely agree with Gabrielle. There's been a lot of research into, the evidence base in terms of recruitment and retention in the allied health workforce and the health workforce more generally. So we know that things like rural background, a strong rural health curricula as part of your training, and quality rural clinical placements as an undergraduate are key to ensuring that we've got people with an interest in establishing a rural career. There's a lot of research being done at a local level, though, that backs up some of the stuff that Lyndon was talking about, that looks at the importance of orientation and onboarding, almost like a concierge type service, to attract and retain health professionals into rural communities, because you're not just recruiting the health professional, you're recruiting their family. So you need assistance with enrolment in schools. You need to look at the spouse's job and whether or not there are job opportunities and career prospects for the spouse. So there's a broad range of things that have to be looked at in terms of the recruitment and retention. In terms of professional development, a lot of the work that SARRAH is doing at the moment is with regard to the implementation of the allied health rural generalist pathways. So people would be aware that there is a GP rural generalist pathway. That means that GPs, when they're working in town, may have intervention skills in addition to general practice such as anaesthetics or obstetrics. For the allied health professionals, it is, as Gabrielle described, the fact that we have to draw from a range of funding streams and be able to treat all manner of clients from birth to frail age. And so being able to attract people with that broad skill set and retain that broad skill set is really important.
Thanks, Kath. Really helpful. Lyndon, what do you've grappled with attraction and retention, but you're also growing your own. So yeah. What's your interpretation of this challenge?
It has always been a challenge for small health services. We've got to compete with all of the big health services. So if you're looking at nursing, allied health, it's a hard road on its own, because they get sucked up by the bigger agencies quite quickly. So that led us to, let's build our own model, really. Not quite. Nursing was the first of ours because we actually couldn't fill shifts. So we resorted to the to actually the training of overseas graduate nurses who were either resident in Australia or were coming to Australia, and that kind of solved the problem for us for a while. But we needed to go further than that, because we understood that people living in our communities, many of them who wanted to study, couldn't afford to move to study. And this has been a really big issue for us. And it's been one of our success factors that because what we're doing now, and we were doing it before, which is kind of producing, all right? We take our certificate for PCAs and turn them into ENs by paying somebody else to do it and paying for the travel and all that. Well, we actually found a way through that so that we could do it ourselves. So we and I talk many times about taking a great colleague of ours who started work with us as a cleaner and is now a registered nurse working for us in one of our health services. And there are multiple examples of actually taking ownership of it and investing in it where you have the capability yourself. We believe in lifelong learning, and we believe in industry-based education because we bring them into our health service. They are part of our health service from the very first day they start their education, and all of them in the end spend some time in employment with us as they grow and develop and move on. Yeah. So the industry basis of our approach, I think, has great merit. It's actually worked. It's actually worked for us.
Yeah. Thank you, Lyndon. It's lovely to hear the sort of the local and very much sort of locally based response to what are these really big sort of systemic challenges. It's really encouraging, I think, for those of us who are waiting for systems to change. That happens very slowly. Nina, we had a question from Scott. It's sort of a related question about the concern about balancing the availability of telehealth and the ability to get it sort of through telehealth a specialist message to a patient. But both Gabrielle and Kath have talked about the importance of that local backup. So how do you balance that need around telehealth and local skills? Can you get Scott there, Nina? Scott, we might ask you to put your question to the panel.
Good morning, everybody, and thank you very much for the conversation. So yeah, I'm particularly interested in how do you balance that, because we all know that there's a range of workforce shortages in rural and remote Australia. The evidence is very clear. The challenge, I think, is around, and what we have seen as a result of the COVID environment, is that a lot of the health professionals who were reluctant to engage with technology are really now celebrating that opportunity. How do we create an ecosystem at the local level which builds health literacy within the community, enables, as you were saying, Lyndon, that local workforce development when the resourcing pool is not often within that community? So we have the Allied Health Rural Generalist Pathway, we have training dollars for medicine, and we have it for nursing. But within that broader local workforce, there is not a really strong funding commitment, and then we get caught back through the states are responsible, the feds are responsible. How do we actually raise that conversation and actually drive resourcing into that pool? Because that's where I think we'll get the best bang for the buck and actually enables a continuity of care within a health literate community by building local capability and capacity. Thank you.
Thank you, Scott. I think everybody will probably have some commentary on that. Lyndon, would you like to start with your views on that one?
Yes, I can do that. I didn't say before, Scott, anything much around the allied health workforce, and I'm going to go here because I happen to be married to an allied health professional who has benefited greatly by the use of these wonderful video conferencing technologies. And how do you do that? How do you do that at a broader community level? I mean, how does that happen? Our story is interesting, and I'll just give it to you as it stands. We've never really employed a large number of allied health professionals. When we did, because we're a multi-campus model of service delivery, we found ourselves losing 60% of the time of those professionals by travelling and so on. It's a really big issue. But of course, then the Commonwealth Medical Benefit Schedule changed, and they could get access. So we entered into new relationships with our existing workforce, and then encouraged, there are only small numbers of private practitioners around, but what we've done is established formal relationships so that they provide services to us. We actually provide a funding base, if you like, that enables them to grow their own business for themselves. And now we have access to all sorts of allied health professionals. We don't employ them all. I think we only have 2 or 3, dietitian and something else. I've forgotten. Doesn't matter. So the way that we operate, establishing those relationships across our community, actually enables the growth. Because we're not doing it all on our own. We have a pool of something like 30 allied health professionals out in our communities now who are providing services to clients in their own right. And we have seen them take up with great alacrity the technology. We have a team that we support, a team of people operating what we call the PACE program, which is pulmonary and respiratory disease management exercise program, and they have, along with their clients, embraced the whole model of video conferencing. You can do your own exercise in your own home and all that kind of stuff. So there's the use of technology on the one hand, and there's relationship management strategy on the other. That's the way that we've worked it.
Thanks, Lyndon. Kath, you had some really nice examples, in your presentation too. How do you approach this?
I think that Lyndon's examples there are spot on. I think there's a clear role here for local health networks and primary health networks in supporting local businesses to provide those services where you're having trouble accessing them. It circumvents a lot of the issues that we're going to have with regard to making changes to MBS items to make allied health services more accessible. It enables the use of telehealth. You can be far more innovative in terms of the way that services are provided. You can use assistant workers. So as long as you've got good, strong relationships and governance arrangements that support high quality clinical care, you can do some really innovative things at that local level through the local health networks and the primary health networks. So I think that Lyndon's a great example of that.
Thanks, Kath. Gabrielle.
Look, I was just going to add there as well that, look, there are already MBS items in the patient end services, and it's not available across the board, but I do think that there are some real benefits in that kind of model where you might have, you might have a patient sitting with a physiotherapist or a psychologist, and they need to sort of connect with a specialist that might be in the city. And I see that kind of model being really useful in terms of upskilling that local workforce. And there are some good examples in the literature around that that's done a bit more in that sort of acute care setting where, the physiotherapist might be talking to an orthopedic surgeon in the city and doing things in that setting. But I think it can also be done in the primary care setting as well. So I think that's one way of upskilling your workforce and using that, the benefits of telehealth. And I think there's also opportunity for doing, multidisciplinary teams. You could get a lot of a better connection of care if you had, your GPs and allied health nursing practice nurses, if they're all working together in doing that in a sort of a telehealth kind of a way, I think we can actually do some real good in getting better continuity of care for the patient as well. So I think there's lots of ways in which we could use, telehealth really effectively in rural areas. But I think at the other, we also have to balance that, of course, with making sure that, we don't have virtual healthcare done from the cities, into the bush without making sure that we've got a really strong health workforce on the ground.
Yeah.
So that's why I think that patient end services can be so valuable.
I think that's a really important point, Gabrielle, and all three of you have made that very clear. It's not an either or. It's not telehealth or local. It has to be both. You've got to be able to have those people on the ground in those communities to do the face-to-face follow-up. The telehealth can be a fantastic enabler, and certainly the speed with which the government has moved to change the funding mechanism of that's been very impressive. And I think you've given some really nice examples of how that brings specialist expertise to quite a remote place at very low cost. But it's got to be backed up by those local skills and by that local workforce. And I think that's one of the, we had a number of questions about how is COVID-19 going to change the rural and regional health setting. I mean, clearly that's one, there'll be greater expertise. But I was struck, one of you had a figure too about, this number of about 28% of patients not being happy with either video conferencing or even telehealth, and Lyndon's nodding. This number of somewhere between 25 and 30% of regional households either not having a good enough connection, not being confident in using a connection, or simply just not being happy to use a digital connection as a substitute for a face-to-face visit. That 25 to 30% number is coming up in lots of different contexts for us. It's pretty much the difference in many, if you look at the NBN data, the difference between the availability and the take-up. There's still this sort of 25 to 30% gap. Now, we can't run a rural health system that excludes 25 to 30% of the people, particularly because they're likely to be the most vulnerable. So, it really is, we talk about balance, but it really is a matter about building up both aspects of this, I think, so that it actually works effectively. I don't know if you have any sort of comments on that, Gabrielle or Kath or Lyndon.
Well, yeah, I certainly think that we have to look at some of that, consumer digital health literacy, and so that people feel competent, but it requires a little bit of, potentially it requires a bit of health literacy as well as the digital health literacy. It also, on the other end, it does require the provider to feel confident about using it. So there's a real need, and we have done that through our pre-budget submission, sort of put in there that we really need to be upskilling both the workforce, but also your consumer at the same time, so that everybody feels capable and confident and knowing when to use that sort of technology and when we need to be face-to-face and what things can be substituted effectively. I think, we also need to address the fact that, is telephone going to be suitable for everything? We have to look at those quality issues around the telephone as opposed to even the video conference as well. So there are a lot of things that still need following up and developing, and to make sure we're really rigorous around quality, because I don't think we want to be using telehealth in a way that doesn't really address the issues that need to be addressed for that person that's walked in the door, if you know what I mean.
I think that's right. Thanks, Gabrielle. Kath?
Look, I'd agree. I think that one of the examples that I gave earlier was that one of our practices got good results where they invested time in supporting the client and their family to understand and utilise the technology so that they can then focus on the therapy rather than the technology. It's important to note that none of that would have been funded. And so, it's another example of how allied health professionals subsidise, the health system in general off their own bats to ensure that they get, quality outcomes. I also agree with Gabrielle's point that that telehealth is an adjunct. It's not a substitution where you can't get local services. It should always be an adjunct. There's always going to be ways that you can find combinations. So whether or not that's, through the development of the local health workforce and particularly therapy assistants and other health assistant workers at the patient end of the exchange to support the patients and ensure that they get the best out of those services. So there's a lot of work that can be done to support the development of the assistant workforce to help that.
Yeah, thanks, Kath. And Lyndon, we're just about out of time, but do you have a comment on that?
Oh yeah, a very simple one. We can't avoid the psychology of human beings, really. We had a video conference with our community advisory groups last month. We had about 30 or so of them online, and the common conversation was about, wouldn't it be really good to get back together again? we are human beings, and we're social, and when it comes to really important things, I mean, all health is personal. You know, the whole definition of health is personal. Then it's in that relationship, a set of relationships that we've built as a system for a long period of time. We can't avoid it.
Yeah, thank you, Lyndon. And look, thanks to all our panelists. It's been a really rich and not controversial, but sort of heartfelt. And I think we've really touched on some of the underlying issues around a pathway forward for all health. So thank you very much for all three of you. We are out of time. We'll make a recording of the webinar. Will be available on the Regions Rising website, regionsrising.regionalaustralia.org.au shortly. Please keep the conversations going on social media. There's a lot to talk about. We're seeing a stream of questions and discussion points still coming through on the chat, as well as the Q&A. And by all means, do pick up on the resources that we have made available this morning, the fact sheet on rural regional health and the lovely case study of Lyndon's Alpine Health Group. So thank you very much. I hope you've all got something out of it, and we look forward to seeing you at our next webinar.